Proctor. I'm a teacher for Intuitive. So that means that I travel around Europe as faculty and as a trainer for this robotic machine that I'm going to explain about and talk about. I've been doing hernia surgery from open, inguinal, incisional to laparoscopic, and started robotic surgery about 4 or 5 years ago. The robotic assisted surgery is much older than that. I think the hernia surgery has been introduced at least 10 to 12 years ago and is really gaining ground now. What I've made is a short presentation in which I'd like to just show how fantastic the tool is to help surgeons to do the surgery. So just to start with, a robotics operation does not mean that the robot does the operation. It only means that the surgeon has a tool that assists during the operation, which is a kind of a laparoscopic or minimal invasive operation. And the big goal is in robotic surgery is that you can do a big operation via keyholes. So you can make 3, 4, sometimes 6, 7 small incisions, and via those incisions, with the help of a robot machine, you can do a very large operation, which has advantages. And I'd like to, with this presentation, just quickly indicate what the advantages are for surgeon and patient. And then I'm ready to answer your questions. So I have this talk from with the help of Philip Muisoms. He's a colleague from Ghent, and he actually is the big initiator of European robotic surgery. And in this slide, he shows via the help of Intuitive how many operations are being done in the United States now and how large the ventral part of that is. So you see in the left that inguinal hernia and ventral hernia are being done by robotic assisted operations in very, very large numbers, especially in the United States. So what does the robot do? It gives us an enhanced visualization. It's 3D. It's 20 times enlarged, and it thus shows beautiful anatomical details. Here you can see a close-up, which means it's 20 times magnified, and the surgeon sees it in a 3D environment, which gives all the details that that the body has to offer, like nerves and vessels and muscle borders, etc. It has a improved dexterity, so the wristed instruments help you to do maneuvers that you can otherwise not do with a straight stick, as we call it, laparoscopic operation, which aids us during suturing, adhesiolysis, and it has a complete tremor control. So if you are a surgeon with a small tremor, you will not see it in the instruments when the machine translates your movements of the hand to the instruments in the body. And here you can see a very short film on how nice that is. So very up close, you can see the cutting, and the instruments are modulated, so you can move them in all directions according to your own movements in your hands and fingers. Here you can see suture maneuvers. So the movements the instrument now makes on the ceiling, as I say it, because you're working in the top of a, sorry, then my phone is going off. In the top of the abdomen, you're looking from bottom to up. Here you see 2 muscles, and the suturing is done in such a manner with these modulations that it's easy to do instead of using a straight stick. So the ergonomics are improved for the surgeon, the angulation, the physical strain, and the lengthy procedures. Here you can see Dr. Muisoms performing a straight stick operation. He has to bend over, bend down, and do this for 2 or 3 hours if necessary. And here you see what happens if you do it with a robot. So on the left, 2 pictures are a straight stick endoscopic operation. On the right, you see a robotic assisted position of the surgeon at about 3 to 4 yards from the patient. There's an increased surgeon's independence. So the camera is completely in control of the surgeon using his feet and clutches. So there's an operative flow and it's closer to the target. And here you can see a small film in which the surgeon has a completely steady camera, which is not being held by an assistant that has tremor and slight movements. No, this camera is completely stable and moved by the surgeon's same instruments. And here a mesh is being placed, which is also nice to see. This is what we do in hernia surgery. We place meshes over the defects. There's the immersive increased attention or our atmosphere. It's a completely calm and silent environment. You're in complete communication with the people in the room by a microphone. But it gives this sensation of being completely in control of the operation and thus the advantage of the patient. Here you see an example of left up top. You see some holes. You see two muscles. The peritoneum and the fascia has been taken down. It's hanging in the lower picture here in the bottom. And here you see rectal diastasis, as we call it, with holes. Here you see these defects. These are hernias. Here is another one. And in the next picture, you see that this is being closed, and then it looks like this. So the muscles have been closed, and then we put in a mesh, and then we close the peritoneum. So the advantage of this operation is that we don't push a mesh in the abdomen, but over a closed abdominal wall. So we don't bridge gaps anymore, but we actually close, restore the abdominal wall and force it with a mesh. Now, what are downsides? There is some criticism that it takes a lot longer, that it's much more expensive, and that, is there a clinical benefit is still something that for certain indications has to be proven. And in this slide, I won't go into detail, but he shows the literature that is coming from all the studies we are doing, all the research, that the robot has advantages and, of course, some downsides. This is a lady that was operated the day before, huge hernia. And I think that the biggest advantage of doing very, very big incisional hernias with a robot is that the length of stay in the hospital is reduced from 6 to 8 days to 1 to 2 days. And it's amazing that, doing something through the keyholes has such an advantage. So this operation can be copied by doing it with the robot with just a few incisions. Okay, so in view of time, I'd like to stop and hope to have explained what the advantages are of a robotic assisted operation. And I'm ready for your questions.
Okay, thank you. That was really interesting. What I was impressed with, I saw one in Barcelona recently, and the view is what you get inside the abdomen is really clear, isn't it? So I had to go on the Hugo one. So there is more than one type of robot, isn't there?
Yeah, there are 3 types now. There are 3 companies that are building one. The Hugo, as you mentioned, is from Medtronic. They are the second in the game, but Intuitive has maybe a 10-year advantage in development and in technology. But it's great that there are more types now. It's very important for patients also, because competition means improvement of quality and lowering of prices. But it is a fact that Intuitive has a big head start, and there are computers, there are robotic machines coming up now, which is good. Okay,
that's great. So what Harold sent me some literature about it, and the robot comes in 3 parts, doesn't it? So you have your console, and you have the console over the patient that is you're moving that, aren't you, from your
surgeon's console and a patient console. And then there's the bed. Some modern beds actually can move with the robotic instruments. So that means if you want to reposition the bed, the robot will follow that.
Wow.
That's the most important one. But we try to work with 2 consoles, and in one of them that you can actually do the education and the training. So you have a dual console. But actually, you work with the patient's console or cart, you call it, the patient. Yeah. No, 3 things. You have the patient cart with all the machines on it, like the diathermia and the pressure for the CO2 insufflation. Then you have a patient's console, which are 4 arms, and each arm can take an instrument. And then you have the surgeon's console, from which you do the surgery.
So can any surgeon use a robot?
Well, no, because there are two things that are very important. You need a robot. And let's be honest, these machines are very expensive. And for example, in the United States, they have hundreds of machines per state, and sometimes even more than 10 for one hospital. Intuitive is from San Francisco, and they started development there. I think that also the manner of investing in new technology in the States is much quicker and more ambitious than we can manage in Europe. And for example, in Holland there are 40 robots, and usually a hospital has one and sometimes two. Many hospitals don't have a robot. That's one. And the second thing is there's a learning curve. So Intuitive, and that's why I'm also one of the proctors, is doing really a lot of effort into training the surgeons to start using the robot when they have really gone through a very strict learning phase, a training program. And then we've made a pathway in which you don't just start on the robot. No, you first have a discovery course, and then you have to do in a simulator 30 hours of training to get used to the machine and how it works. Then you have an in-house training. Then you go to a laboratory where on cadavers or on pigs, you get a training program, and then you get proctored. So in the first operations you do in your own hospital, one of the proctors, like myself, comes to assist and to show the way and to help. And then you start with easy cases. So there's a big program that you have to follow if you have a robot, because it starts, of course, with exposure to the robot.
Yeah, okay. So what should our members ask their surgeons about their experience with the robot?
Well, the first question could be, do you have a robot? And then the second is, what training program did you follow? And I can tell you that the Da Vinci machine, which is a intuitive robotic machine, almost all surgeons have followed a strict program. So you can ask the question, of course, how have you gone through your learning curve, and how experienced are you doing this operation? And that would help. But I think that what we can really probably say is that the surgeons that are using the robot have gone through strict training programs, because we don't want, the machine to be used by somebody that is not safe and not acquainted with, the typical specifics of the machine.
Yeah, that's good. That's good.
And what we'd like, you could also ask, did you do hernia surgery before you started on the robot? Because it really is important that you start with open surgery, and then you go to laparoscopic surgery. And if you've done that a lot, then your step up to do the robot is great, because it becomes easier to do the operation.
Right, it's like a stepping stone.
So you should ask maybe the surgeon, are you a dedicated hernia surgery, and is this a big part of your practice, and how long have you been doing it, could be a question. And all these are indicators of quality. We know that volume matters, so that's always a good question to ask.
Okay, so like the EHS, there you run courses on robotics, don't you, before the conferences? Is there an argument for that to be a compulsory part of hernia surgery for robots?
Well, that's a difficult question to answer, because there's no way that we can speed up, as you know, there are in Europe 700,000 patients with hernias. And the exposure to the robot will be a big issue if you make that compulsory.
Right.
There are very, very good surgeons that do it open with excellent results. There are very good surgeons that are really very, very proficient in doing it laparoscopically without a robot. And they are doing good techniques, and they are doing safe surgery. So I would not like to go away this evening by saying that every patient needs a robotic assisted operation. I'm just indicating that it's innovation which really helps to do the technique in a safe manner. It helps the surgeon to see better, to work easier, with better economics. But we're not going to say that, that it's the only way to treat a hernia. That it's not a fact. But
Okay.
I do expect that it will increase because, we're following strict training programs, and everybody with a robot says, well, this is easier than doing it laparoscopically. And it is a fact that some laparoscopic operations you cannot do. So then you have to do it open, unless you have a robot, and then you can do it with the robot. So there will be centers, I think, in increasing centers that can state we do it with the robot. So certain indications, you should maybe go to a center to see if the surgery can be done minimal invasively.
Okay, so yeah, I have a question here that's just come through. Do you think that for inguinal hernia, it's better to use the robot? Should a patient search for a hernia clinic that can perform with a robot?
No, I don't. No.
No.
Inguinal hernia surgery can be done in different manners. I'm a typically inguinal hernia surgery since I've started my practice. And I think that you should tailor inguinal hernia surgery to the patient. And that means that you should, as a hernia surgeon, be able to do it in an open manner with a Liechtenstein, which is an excellent technique. You can do that under local, which is a truly excellent technique for very, very many patients that don't need to go or don't want to go under general anesthesia. Then you have the laparoscopic operation, which you can very well do with a straight stick technique. So the minimal invasive inguinal hernia technique, like the TEP and the TAPP, they are completely, how do you say it, have been developed into excellent ways of treating a patient. And the robot makes it easier, but it takes a little bit longer, the whole procedure. It's more expensive. So what I do myself is I use the robot in inguinal hernia only for very difficult cases, like recurrences. In seldom cases, I remove a mesh with the robot, which makes it safer and easier. But the standard inguinal hernia repair does not have to be performed by robotic assisted surgery, but it can be. And I know in the United States there are hospitals where the surgeon will say, I'm a robotic surgeon and I will do your inguinal hernia robotically. Yeah, but in a normal practice in Holland, sometimes we do 8, 9 inguinal hernias per day. And there's no way I could copy that with a robot. So it makes it much more expensive to do it with a robot.
Okay. So is robotic or laparoscopic surgery better or safer for a patient who's overweight than open surgery?
Minimal invasive surgery is better for overweight patients. Yes.
Yeah.
And some incisional hernias are very difficult to manage laparoscopically in overweight patients, and then I would choose a robot. But before saying this, I think we should acknowledge that we like to prehabilitate patients. So actually, you should not operate on overweight patients until you've done the biggest effort possible to make them lose weight and become, healthier before they get the operation, like stopping smoking and like doing physiotherapy and getting lung assistance for pulmonary patients. And after losing weight, the operation becomes so much safer. And then, yes, if there is still overweight and there's an operation is necessary, a robotic assisted operation has advantages in the heavy patients.
So why is recovery thought to be easier when you've had a robotic assisted surgery?
Well, the fact is that it's minimal invasive. So when you do a robotic assisted operation, you can close a gap of 10, 12, 15 centimeters via 6 small incisions. And the alternative is not to do it laparoscopically because it doesn't really work with straight sticks. So the alternative would be an open operation. And doing such hernias in an open way with a big incision has the complications of pain, of wound infections, of wound problems, of skin problems. The patients usually need drains and they need an epidural catheter, and then they need a urinary catheter, and then they stay in the hospital 5 to 6 days to manage that. And you can change that operation into a robotic assisted operation with just 6 keyholes. So the complications go down and the length of stay really goes down. And we have some literature coming out now that also indicates that. In my own practice, I've done 200 robotic assisted operations, and the average length of stay in incisional hernias that are large is 1.8 days, something like that. And
Wow.
and I cannot copy that with open surgery.
No.
So that's why what I hope is that the next phase will be that we create networks in countries where a center with a robotic trained team can do the bigger operations robotically and do this together with surgical teams that don't have a robot.
Yeah. Okay. So we have had some members who've had robotic surgery and then suffered from extra pain from trapped gas. Why is this? And is there anything they can do to help with that?
With trapped gas?
Yes.
The gas.
Do you pump gas into the patient when
it's CO2, and CO2 is you breathe it out of your body within about 24 to 48 hours. And what we usually also do is we suction away the gas as much as possible. So this should be a rare complication. If you have a gas, if you have an abdomen full of gas and you leave it there, and when finishing the operation, it'll take 2 days for the patient to become comfortable. But otherwise, after that, there's no more gas in the abdomen.
Okay. So when you're using the robot, Martin, do you miss using your hands? When you got your hands inside a patient's body, you're used to feeling things, and the robot won't be able to have that sensation, will it?
Well, excellent question, because I didn't mention that as one of the downsides of the robot. You don't have tactical feedback. So when you push your instrument, you don't feel the pressure of bone or of a muscle. So you have to, that's one of the learning phase activities that you need to learn. You need to learn what happens when you touch bone. And then you need a combination of your eyesight, your experience, and knowing what happens when you're close to bone. The machine does start shaking a bit if you push it too hard. But for example, tying a knot with a thin suture, you have to do that with eyesight and know how tight to pull on the knot. If you do that a bit too much, it'll break, because the machine is very, very powerful. So you have to learn to work without tactical feedback, and we do. Luckily our 7 functions are very quickly adaptable to something like that.
Okay. So another question I've been asked is, are patients missing out on their benefit because they cannot access robotic surgeries?
Well, yeah, that's a moral question. Yes, some are. I think that on balance, we have so many well-trained surgeons doing excellent operations without the robot. So you can treat every incisional hernia without a robot. But in some cases, they might have a bit higher risk of a wound complication or pain or recurrence because they have not been operated by a hernia surgeon that has been well trained, that is experienced, and has a robot. And those are things that you have to factor in when you are a patient. So I think those questions you have to just discuss with your surgeon. But again, I'm not here to say that every patient needs a robotic surgeon. I think every patient needs an experienced surgeon. There is a hernia surgeon, and then some have excellent results with open surgery because they follow very strict rules in avoiding all these complications. But the advantages of the robot, they are there. That's a fact.
What would happen if during the surgery you realize that you can't actually repair it with the robot? You can't repair the hernia with the robot. Has that ever happened?
Yeah, sure. We have three types of operations. One is that you can do completely robot assisted. Some are hybrid operations. So what we do is we start with a robotic assisted operation and we do the whole dissection, which takes 2-3 hours. You have all the advantages of the patient not having an open wound, which means you can control everything much better. And then the last phase of the operation, you have planned conversion to open, which means that you have to, in some cases, take away a lot of skin. You can imagine that very large hernias, if you close the abdominal wall, they will have a big balloon of skin over it. Well, sometimes we resect the skin open. And then in some cases, I've had a complication with the robot and I had to open the abdomen, which is no problem. You just remove the robotic arms and you go back to open surgery, which can be necessary in certain cases, yes.
Okay. Are there any hernia surgeries that you cannot use the robot for?
Well, sometimes technically you have to just, put your hand into the abdomen and use a knife and scissors. Those can be cases in which there have been prior operations, too many adhesions of bowel. In the seldom cases, we do an operation in which a prior mesh has been placed and it's completely stuck and you cannot, do anything with the robot to open that. So yeah, there are some operations you need to go to open or start open. The ones that have skin problems, the ones that have their bowel attached, adhesive to the skin, you have to remove the skin and sometimes bowel. Those are typical operations that you cannot do robot assisted and have to be done open. So the complex cases can be just too difficult to manage with a robot.
What are specific complications for robot surgery?
Well, we know that in the learning curve phase, it can be difficult to identify the correct planes between muscles. And in my view, that's a training and experience problem. And then you can cause very bad complications like splitting the wrong muscle, and you'll be making a new hernia instead of fixing an old one. Sometimes in the robot, you don't see everything because you're working so close to the problem you're fixing that what's happening on the side and behind you is out of your sight. And I've had one complication with that, in which the bowel was stuck to the abdominal wall and I was moving my instruments and I was seeing the scissors, but I wasn't seeing what the instrument was doing to the bowel that was adhesive to the abdominal wall. So that could create a complication. Well, if you have bad luck in surgery and it's difficult, you can be close to a blood vessel and it starts bleeding. Sometimes you have to quickly open the abdomen to fix that. And experienced robotic surgeons are even now training to solve those problems with the robot itself. But that's also advancement of technique and experience. But I think the most important catastrophes that we call of the robot are not being well enough trained in looking for the correct planes to be able to place your mesh outside of the abdominal cavity.
Can the robot do a mesh-free repair? Can you do mesh-free with robot assisted?
Yeah, sure. Yeah, you can very nicely, as I've shown in one of the pictures, you can close a gap with sutures very nicely, and the abdominal wall will be closed. We do know that in many cases this will be an increased risk of recurrence, but you can close the abdominal wall, the holes. You always do before you put in the mesh. So if you don't put in a mesh, you close the defect, and in some cases you might have agreed with the patient not to use the mesh.
And so another one is, where is robotic surgery heading in terms of hernia surgery?
I think that the indications will increase. I think the number of surgeons that are trained and able to use the robot will increase. and that will be a slow evolving, it won't be a revolution, but an evolution, which will take time for hospitals to invest, to train, and then I predict that more and more patients will be treated robotically assisted. Yeah.
Okay. Is mesh in robot surgery always placed inside the abdominal cavity?
Well, almost never. What we try to avoid in hernia surgery has evolved from putting a mesh laparoscopically into the abdomen without even closing the gap. And then we've gone on to closing the gap and putting a mesh in the abdominal cavity. And then you tacker with little screws the mesh to the abdominal wall. We found out that that's a good technique and it's still used a lot, but there is a higher risk of adhesions of the bowel to the mesh, and the sturdiness of the mesh is less because it's not sandwiched in between layers. And now we've evolved into the philosophy that which still needs some scientific research and proof, but the philosophy now is we close gaps and we don't put mesh in the cavity. So all the meshes that I put in robotic assisted are retromuscular, as we call it. So they are behind muscle, but within the peritoneum or fascia of the muscle. And there are cases where that's not possible. And then you do the intraperitoneal mesh. So it's still necessary. And let's say by about 5% of my cases, there's no way that I can split muscles to put the mesh in the best position that I feel it should be. And then I'd have to convert to putting the mesh against the peritoneum and fix it with sutures. But that's a second choice now. And the first choice is all mesh outside of the abdominal cavity.
Okay, so this one's come from Willem, and I don't quite know what he means by this, but he says, do you use any other types of mesh for robot surgery?
Well, the meshes that you can put between muscle layers or between the peritoneum, which is the first layer that covers the abdominal cavity, and muscle, you can use all polypropylene meshes that are made and are available in the market, because they don't need a bilayer in which one part of the mesh adheres to muscle and the other part gives a barrier to bowel. So the bilayer or the composite meshes are used when you do an intra-abdominal mesh, and the polypropylene simple, as I can say, mesh are put between muscles and outside of the abdominal cavity. And then you have 30, 40 types of mesh from which to choose. You have mesh that are adhesive. There are meshes that you can glue or fix with sutures. There are meshes with two different types of materials. And some surgeons, have a preference of certain types of mesh. We have strong mesh with, small pores that sometimes are necessary for big holes that need more of a buttress. We have lightweight meshes when we think that the least heavy or the least bulky mesh is fine, like in inguinal hernia surgery. So there's a lot of types of mesh that we have to choose from and that we need to choose from.
Yeah. So another question I've been given is, how do you decide which patients are suitable for the robotic assisted surgery?
We have in hospitals now teams that we're a multidisciplinary team. For example, in my hospital, I have very little access to the robot, so I have a huge waiting list for robotic assisted operations, which means that I don't do inguinal hernia repairs. But you could, but we don't, because we need the robot for incisional hernias. And then with a team, we discuss the patient, the necessary prehabilitation, the possible techniques, the possible mesh that we would need, and then we choose. It is a fact that you can only choose for the robot if you have a robot and a robotic trained surgeon.
Okay. So can you repair a recurrence? using a robot?
Yes, you can. Yeah. As I've said before, not in all cases, but recurrence sometimes has already a mesh in it. That is not a contraindication. What you need for a robotic operation is a good access. So you have to be able to put gas into the abdominal cavity so that you can have working space and see, how to solve something. Then when you are in the abdominal cavity, you have very often in these cases a lot of adhesions of bowel to the abdominal wall, maybe even to mesh. And you take those down, which is very well easily done with the robot. Well, it's never easy, but you can really see how you do your adhesiolysis because of all the advantages you have. And then you have sometimes a mesh and next to it a hole, a recurrence. And then you choose between taking away the mesh and doing a completely new operation. In some cases, the mesh that is in there but not doing the correct job stays in, and you have to do a kind of an improvisation with a new closure and mesh. I would say that's work for experts, and I always advise my patients to have that performed by a dedicated hernia surgeon, which is in most hospitals I know already the case. And then, yes, you can do it with a robot.
Okay. Is the robot suitable for an umbilical repair? We've been asked.
I think that most umbilical hernias can be treated with an open small incision and a suture of the hole if it's small, or a very small mesh that you can easily put in there via an open manner. That's a very safe, very reliable operation. There are patients that you'd rather not do it with an open incision, like heavy patients. If you have a very high BMI, you don't want to make incisions because they have more wound problems, more infections. Then you would like to do it laparoscopically. Small umbilicals you can do with a laparoscopic operation. You don't need a robot for that. And I think that the ones that I would do robotically are the ones that also have a rectal diastasis. So they sometimes even have 3 or 4 holes. There's an umbilical hernia, and then above that there's another small hernia in a demarcation of the rectus muscles. Post-pregnancy is a risk factor for that, and patients that have been very morbid obese, very heavy, often have a rectal diastasis. And then I'd like to choose for a robot-assisted operation because I can manage the whole problem and not just a small hole. We know that the recurrence rate is higher if you just close a small hole in a very weak abdomen. So, managing the whole rectal diastasis, which is a very, very weak, thin layer of muscle fascia, by closing it completely, which you saw in one of my pictures, and then putting in a mesh is the indication I would use for a robotic operation.
That's great.
But umbilical hernias in most cases can be done with an open or a relatively straightforward laparoscopic operation.
Okay. So does anybody else have any questions for us? I've asked most of what we've been given. So the one thing that strikes me with the robot is we're just about beginning in this, aren't we? And it's going to evolve over time. Do you see a time when all surgeries are going to be performed by a robot?
That's looking into the far future.
Your magic ball out.
Yeah, we are, we want to go to the moon and we want to go to Mars, and we build rockets because we can. It is a fact that, it's very, very attractive to do robot-assisted surgery. And if we can prove that it actually is safer and saves money because you have less complications and a really hugely decreased length of stay in the hospital, then it's also a very efficient and effective method of using robots. And I do predict that the hospitals will be using more and more robots, not just for hernia surgery, but for cancer surgery, increasingly for intra-abdominal hernias, like diaphragmatic hernias, etc. So I do predict that we will have an increase of robotic-assisted operations. And I believe personally that we will be able to prove that there are very many indications in which we will be doing safer and more efficient and effective surgery.
So one question I've just popped up is, are you always in the operating theatre when it's a robot assisted? Is your console outside the operating theatre?
No, it's always in the operation theater. You have to be able to go to the patient's bed, you know, in just 2-3 yards away. But technically, you could do a robotic assisted operation from New York with a patient in Amsterdam. You know, that technically is possible. I mean, it's not done yet because it would be legally a challenge. And if something goes wrong, you're really in trouble. But the machines are able to be used, you know, at a longer distance. So yes, I could stay at home with the surgeon's console. And if somebody puts in docks the patient and puts in the machines, it would be technically possible. Just like you can send a rocket to the moon and it lands there without a human being in it. We have the technology to do it, but it's not happened now. All robotic assisted operations have a surgeon's console in the patient theater with the surgeon right close to the patient.
So do you still have all the scrub nurses and all the full theatre team in with you then?
Well, I think that you have great questions, Jackie. Compliments to that. Another advantage of robotic surgery is that in many cases, you only need one surgeon and one scrub nurse. Because I do my own camera work and I do the instruments myself, that if you use 3 arms and maybe even a 4th static arm that, you know, you just pull up a tissue or pull up the bowel with it, then you only need a small team. You always have a scrub nurse because you need cleaning of the camera and putting in different materials. Somebody has to put in a suture and the mesh, and somebody has to sometimes change the scissors to a suture holder. So there's always somebody at the bed. But that used to be in open operations, always a resident, a registrar, or a second surgeon, or an assisting nurse. And that person is sometimes now managed, it doesn't have to be at the table. And actually we have in my hospital, a liver surgeon, and they used to do the liver surgery with 2 surgeons and in an open manner. Then he started doing it laparoscopically with 2 surgeons. And now he does liver resections alone, which saves a whole surgeon for a full day, and he or she can do something else. So it saves personnel, but there's always somebody at the bed.
Do you see then that, and I know you may not want to do this, that surgeons can carry on working for longer then using the robot?
Yeah, well, I hope that's a fact, yes, because you know, I'm now over 60, and I've ruined my shoulder by doing a lot of laparoscopic inguinal hernias, and you have to hang your hand, you know, like this over the patient. And we used to do 8-9 patients per day, and 8-9 times about a half hour you're hanging with your arm like this, which is really bad news for the shoulder muscles, the rotator cuff, with the economics of a robotic assisted operation, you sit in a chair and the machine is completely adapted to your specifics. So the height you can adjust, and the length for your legs you can adjust. And if you bend over a bit or sit back a bit, your back is completely adjusted. And that is so much better for a surgeon. And as we get older, I think you can keep doing surgery longer. There's not a big bunch of scientific proof that this is a fact, but it does seem completely logical, you know, that you can sit down doing the operation in a relaxed manner instead of standing up and bending over.
Yeah, and what they said to me when I saw the robot is, whereas you'd have to use some serious force sometimes during surgery, the robot can just be very gentle because it's a lot stronger anyway, isn't it? So will that again aid a patient's recovery?
Yes,
decreasing in pain.
What in static surgery happens is that when you put in trocars, so those are the small little tubes that you push through the abdominal wall, they have a center of rotation in the robotic surgery, which is completely static. So the abdominal wall stays the same during the whole operation unless you put down some pressure. Which means that there are very, very small movements and nobody's pulling on a instrument. There's no pressure in such a manner that the patient could be experiencing more pain by this, and the trauma to the abdominal wall is less. So because of the complete stable situation in a robotic operation, you have advantages of collateral damage and contusions of tissues. And especially in open surgery, we all know the junior, the resident, or the assisting surgeon that has to keep the abdominal wall opened for an hour, 2 hours, which means stretching the muscles, which means, causing small contusions, hematomas maybe. And all that is avoided by doing it with minimal invasive techniques, especially when the robot is helping you.
That's great. So hopefully it's the way forward.
Yeah, it takes time to convince administrators. It takes time for surgeons to indicate with good research that that this is the best way to go. It's difficult because I think that the best study would maybe be a randomized controlled trial, which we're going to do, by the way. But just like in the evolution of laparoscopic gallbladder surgery, hardly any trials were necessary to have every surgeon in the world now do a laparoscopic gallbladder operation. And this seems so logical that this is good for patient care, that I expect that we have to get those prices down. We have to make the machine more efficient. I worry a bit about the environment. There's a lot of plastic involved in covering the Da Vinci arms. I hate that. So we have to tackle that issue. And then we have to make sure that surgeons are well trained to do it. That costs a lot of investment. They have to invest in themselves, but also society and hospitals have to help in that investment. But for many indications, it does seem like a great future because of the advantages that it offers.
Brilliant. Well, Martin, thank you ever so much. I've really enjoyed this tonight. It's been fascinating. I've learned so much from you. It's great. I think we've asked all our questions. You've answered everything for us. So thank you, Martin. It's been lovely to speak to you.
It was an honor and my pleasure. And we'll be back. The EHS, as you know, is really so happy to be working together with patients. And the Facebook group is fantastic. We're getting a lot of questions and we're happy to answer all of them. We have a huge number of experts on board that, as long as you request us to come online to answer questions, we'll be there for you.
Yeah.
So just keeping inviting us.
Yeah, we will do. Don't you worry. You're not all going anywhere. So Hilary says, thank you very much. Very interesting talk. And Dave said, great session. Thank you.
Okay, wonderful.
So
thank you for being with you.
Yeah, this will be available on YouTube and it'll be in the group as well shortly. So wonderful. Thank you and have a good evening, everybody.
Okay.
Take care.
And
bye-bye.
Thanks, Hakan, for the help.
See you soon. Bye.